Prashant, thank you very much. It's really a pleasure to be here. I come from the East Coast, born and raised there, Pakistani heritage, but being in California is awesome. And I think this is one of the best trips I've ever had, just because I've met so many amazing people. You know, I'm not used to being the dumbest guy in the room. I'm definitely in this room, I am. We have some outstanding, I've met some really brilliant people here, and it's been very, very fun for me to be here. I have a pretty easy job actually today. I'm just going to share some stories with you from the front lines, from the back office, and from the enterprise level health system. My name is Dr. Ghauri. I'm a practicing internist. I've seen the light, and I've now transitioned into integrative medicine, which is just a fascinating area in and of itself. And let me just start with my father. My father, about 5 years ago, had some chest pain. And it turned out that one of his arteries was blocked, and he was admitted to my service at my hospital. And I have a very important rule, which I'm sure Dr. Mukherjee has the same rule, that you never ever treat your parents. So my colleague, who's a fantastic internist himself, took care of my father. He got his catheterization. He came to the room. My dad is a really smart guy, engineer by background, and very with it, very engaged, and he was in the hospital for 3 or 4 days. On the day of discharge, his care went perfectly. On the day of discharge, my partner went to his room. He spent 45 minutes with my dad before he left. And I'm telling you, Dr. Mukherjee might confirm this, but that's very unusual for a doctor to spend that much time with a patient, especially on discharge. The doctors don't spend that much time. Any of you that have ever been in the hospital, hopefully none of you have, but and he's a fantastic intern. I know what he told him, and he gave him the discharge instructions. My dad went home. Good. My dad called me the next morning, 9 a.m., says, "What am I supposed to do with this, and how do I do that?" And I'm like, "Did you hear what Dr. Mueller said?" And he said, "Yeah." I said, "Well, what about the discharge instructions?" He said, "What discharge instructions?" He had no idea that he got discharge instructions. And this is a very meticulous man, an accountant. He was an engineer, he became an accountant. And the point of telling you this story is that things happen in the hospital that are just unexplainable. And when you're in the hospital for 3 or 4 days, you don't really know what's going on sometimes, no matter how bright and how smart you are. And wouldn't it be great if we could have recorded that 45-minute interaction on video? Wouldn't that be awesome? Right? I mean, that'd be fantastic, right? There is a company out there that does that. What is the likelihood of us getting that product in our hospital? Anybody want to guess? 0. I don't know, maybe at your place? 0. Fantastic idea, but the sociology of what happens in our hospitals and in all of our healthcare settings, to be frank, is one of the reasons why we're in such deep trouble as an industry, as a healthcare industry. There's lots of things that prevent terrific work that was like that was just presented from actually making it to the bedside. And so that's kind of where I'm going to focus on today. I'll tell you a little bit about me really briefly. We should all introduce ourselves as father, husband, son, brother. That's what I really am. As I said, I'm also a practicing doc, although I don't see patients very often anymore. And I'm an administrator now. I wear a suit most of the time. And the CMIO, Chief Medical Information Officer, is the workflow expert in the organization. So I do that at the enterprise level. And I'll talk about Trinity Health in a second. And I do that at one of our hospitals, which is really fantastic for me because I get to be at the bedside and be in the ivory tower as well. And I've been very fortunate. I've transitioned my practice into locums. So now I go to all these hospitals all over the country. I try to do 2 or 3 days a month, and it's wonderful because I get to travel the country. I get paid pretty well doing it, and I see all these fantastic processes. I steal theirs, and I share mine as well, and we bring it back. And I also have quite a bit of entrepreneurship, and we can talk about that another time. So I want to talk about Trinity. So Trinity Health is a very large health system. It's the largest faith-based nonprofit health system in the country. We have almost 100 hospitals. in 22 states, and 33,000 physicians, and 9,000 of them are actually employed by us, and about 120,000 colleagues. And we have this really cool vision, to be honest. I mean, Dr. Richard Gilfillan, he's our CEO. He came about 4 years ago, and he set this direction. I won't go through it now, but if you have a chance, take a look at this. This is a really noble mission for any healthcare organization, not just a large health system. And the cool thing about Rick is that he was actually my primary care doctor when I was like a little kid, 5, 6 years old. I've never told him that, but I have to remind him of that next time I see him. I'm going to skip over this one. This is just our strengths as a health system. But I do want to talk about this, pain points, and this is where we struggle. And the good thing about this, well, not the good thing, but this is not unique to Trinity. This is unique to pretty much any hospital, and I'm sure Dr. Mukherjee might confirm some of this. The problems vary a little bit, but for the most part, most hospitals and health systems have these problems. And number one is standardization. Now, with the exception of Kaiser, and there are some terrific Sutter Health, there's some great health systems here in California that struggle less with standardization. But the rest of the country, we are really struggling. We have about 100 hospitals, and the way we take care of your stroke or your heart attack or your sepsis or your pneumonia is really pretty different when you go from one of our hospitals to another, even within the same state. In Pennsylvania, we have about 5 hospitals within a 30-mile radius, and each hospital you go to, you'll get good care, but it's different. It varies. The way it's delivered, the timing in which it's delivered varies. And they're all pneumonia patients, right? I mean, pneumonia is not that hard to take care of. I mean, I'm talking about simple pneumonia. So that's a problem. So we're trying to, like everybody else, we're trying to be the Walmart of healthcare, right? So we're struggling with that. So the other area is process improvement. We really struggle with process improvement, and that's where you guys come in. We know the theory, we know lean, and all of our management are well trained to do process improvement. But as you know, we need data to be able to do good process improvement. Because when we make an intervention, we need to measure to see, did that intervention work or not work? And although we have tons and tons of data, it's very, very hard for us to process that data into something. And again, going back to the sociology, that's a huge part of it, but then we don't have the tools. And that's why I'm so excited to be here, because driverless AI and some of the things that I've seen at H2O, these products are going to help us process that data and make some decisions. Data aggregation, this is another big area, and this goes back to our clinical systems as well. We, within Trinity Health, have 6 different EHRs. And for those of you that don't know much about EHRs, it's the system that we use to track everything that's going on with our patient. So we have Epic, Cerner, Meditech, Athena, NextGen. It's wild, wild west. Now the good news is 2 weeks ago we made a huge decision to move to Epic. And the truth is, that's a good decision. We'll be unified, and the data will be a little bit easier to manage and record. But it's for me, it's actually big job security, so I'm happy about that. But it will help us a lot, but it's going to create some new problems for us as well, because Epic is not necessarily the most interoperable system that's out there. So change management is another area, and again, my official title is Chief Medical Information Officer, but really I should be called the Chief Change Officer, because every time something needs to change, they call me. And I have to put together a plan and actually make it happen. And I have to twist people's arms sometimes. I've broken a few arms. I've broken my own arm too, maybe more than I should have. But change management is very, very tough. It's very hard to get, especially physicians, to change the way they do things, because we're all very well trained. We all have been pretty smart throughout our life, and we don't like to be told what to do. And I know I'm a cowboy, because my way is their only way. And my hospital, if you ask anybody in my hospital, it's the only hospital in the country. There is no other hospital. That's just the way it is. And this is the way not most, but this is the way a lot of hospitals run. They don't think about the way other people do things. It's just the way we do it. Data reporting and dashboarding, this is another area where what work that's going on here can help us. We do a very bad job of sharing data within our own organization. So we have wonderful dashboards and reports for our highest level, executives and kind of the upper level senior vice presidents and, those types of roles. But helping the nurse at the bedside or the doctor at the bedside, we don't do a good job of that. Especially our middle managers, they're the ones that are actually trying to make that process improvement happen. And we have a really poor way of getting them the data that they need. So tools that will help us deliver that to them is what we really, really need to do to advance our objective. And then finally, patient experience and engagement. I told you the story of my dad. That's a story of experience and engagement. He had a very good experience. He was very, very engaged, yet he still could have had a very bad outcome, if he didn't know who to call, on the next day after his care. Okay, so this is what we're actually looking to do going forward. As I said earlier, Epic is going to solve a lot of our problems, and it's going to create a couple of new problems, but Epic is going to be a good thing. I think the large majority of large health systems are trying to decide this, should we go down this integrated clinically integrated network or completely unified, EHR and completely unified process improvement strategy, or should we take this hybrid approach the way we had been taking for so many years? And it's really, really hard, because these systems are supposed to talk to each other, and they're not. And meaningful use stage 3, which, by the way, I don't know if you know what that is, but meaningful use stage 3 and meaningful use has been renamed so basically it doesn't exist anymore, to something new. And this meaningful use, these dollars have been driving a lot of the change that's been happening. Oh, this thing died. Okay, that's all right. The next area that we're really focused on is clinical standardization, as I talked about earlier, treating that pneumonia patient. And to give you another story, everybody know what sepsis is? So sepsis is a very dangerous infection. It's an overwhelming infection of your body, and it has very high mortality. If you get sepsis, you're at very high risk of dying. And so it's a very serious disease. And so we did a very good thing. We said, you know what, we're going to make sure that we get our septic patients antibiotics within 1 hour of their admission. And that's a very noble thing to do, and we set out to do it. We collected the data, we did all the right things, we looked at the evidence, and we created a process where we were able to give our patients that came into the ED, antibiotics within an hour. Very happy, right? So now it's a month later, and we're looking at our data, and we're looking at all of our data throughout the whole hospital, not just the ED. And we're seeing that there are some patients who are 3, 4, 5 hours before they get their antibiotics. And there was a clear theme. Now, this is a month after we started. It took us a month to collect data, right? Now we're looking at this data. This is not, one person. I mean, I'm looking at the data, but we have 5, 6, 7 other people in this room, right? Really smart people that are really, really busy, right? We're all looking at this data, and we're all scratching our heads, like, why are we not doing the right thing for these patients? And it turns out that these patients were our inpatients. So our ED patients were getting terrific care, antibiotics within an hour. But the inpatients, for some reason, it took us 4 hours sometimes to get them antibiotic. And so we started looking into this, and after, quite a bit of kind of scratching our head and mulling and doing research, this is 15, 20 hours later of man hours, right? We realized that there's a very subtle thing in the way these things are ordered that made this happen. And the subtle thing is that when we order a medication or order anything, we can say Tylenol every 6 hours, or we can say, IV fluid at a rate of, 200 cc's per hour, and that every can be given 2 ways. You can order it, every means Q, the letter Q, so we say Q 6 hours, or you can say Q 6 hours H, and that little H makes a huge difference, because that little H means start it now. And if you don't put the H, it starts it at the next scheduled administration time, which is 9 a.m., 3 p.m., 7 p.m. So if you put the antibiotic in for this septic patient without the H, it's going to be given at the next time. So if we order it at 9:05, that patient's not going to get an antibiotic until 3. right? And if the nurse is not paying attention, if they're busy, if the rest of the physicians aren't paying attention, physicians, they don't. Once it's ordered, it's gone. We don't really know. We don't really care sometimes, unfortunately. So this very simple, very sinister issue is what was causing this very severe outcome. And so I bring this up again because this is an informatics problem, right? So this is, again, close to my home. So we have sociology problems, we have clinical systems and informatics problems, and when we just make errors sometimes. We're just careless. That's obviously a problem. Dr. Mukherjee mentioned earlier, accidents and iatrogenic, meaning our fault errors, are the 6th leading cause of death. Almost 100,000 deaths a year. We've improved that a lot, but we are the 6th leading cause of death. We got to do something about this. And again, the only way to really change it, especially the sociologic problems, and I'll end after this little story, is with the data. And this is a story that's very close to my heart because about 16 years ago, I graduated from residency, and I went to my first kind of job. I was on the academic faculty of a teaching hospital, and I was all happy, and life was good. I was getting paid a good wage. I started a brand new service with residents and students and fellows, and it was having a lot of fun and taking good care of patients. But somehow in my mind, I had fantastic training. I was trained at a very good place. But somehow in my mind, I didn't need to wash my hands. I mean, I would wash my hands if I remembered. But when I didn't remember, I said, I'm not going to touch the patient, or I'm not going to touch anything, and it's okay. Because I'm above this rule that you should wash your hands. And that was me right out of residency, right, when you're supposed to be the sharpest. And it took the data, right? So my chief of staff, about 6 months or so, 3 to 6 months after, I kind of realized that I'm too good for this washing hands stuff. Even though it was a question on my boards, my internal medicine board exam had, which of the following is the most effective way to reduce hospital-acquired infections? And the answer was hand washing. I got the board question right. He displayed on a screen just like this that since we went on this hand washing initiative, they put the gel containers all over the place, and they were watching and doing secret shopping, until I saw the data that showed a 50% reduction in our hospital-acquired infections. That's when it clicked for me that, you know what, I better wash my hands. And that's when, and so since then I have a pin that I wear on it's like a punishment for me to remind me that says it's okay to ask me if I've washed my hands. So that's a pin that I wear on my white coat. Well, there you go. That's even better. But again, and I think I'm a good guy. I think I'm a nice guy. I think I try to do the right thing for the patient. But if someone like me can think that you don't have to wash your hands, then, and I share this with you because we're all cowboys. We all kind of somehow, for some reason, our system makes us believe that. I think we're better now. I think trainees coming out of residency now are way better than I was when I came out. But we still have a long way to go, and it's only the data that's going to help us get to that point. So I could talk on and on. Another expertise I have is blockchain. I'm not going to talk about that, but I would love to talk to anybody that's interested in blockchain after this. Prashant?
I figured we could do a panel, and you could hear my beautiful voice again. But I figured that you wouldn't want to. So rather than do a panel anymore, why don't we just open the floor to questions and let them speak? Yes, please.
Thanks, both of you, for your talks. And specifically, I was wondering, especially with the GDPR regulations, and I know there's other healthcare regulations with all the PII information. Have you looked into thought about federated learning? It's a way of keeping your data sets local, and then like having the models be trained in like a secure and federated location?
Yes, that's definitely one of the approaches that we're looking at. There are a couple of different possibilities, and I think for our purposes, there's going to have to be for the raw data, there's going to have to be a federated approach, and then there will have to be higher level combination of the derived parameters in the cloud. So that's where the combination will happen.
Cool.
Regarding the same data thing, when you watch the IPOs in the tech industry, especially in our space, big data, I come from big data, all the tech startups, all their source code is free, open source, but their data never was tightly regulated. You see the same thing. So that's the common problem for all of us. But I had a different question, which is, you're using AI in your research, Dr. Mukherjee, and how do you eliminate false positives? That is, bing, 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 something's wrong, and then people are like, forget it, it's like cry wolf. Right?
Yeah, I mean, that's an enormous problem, and there's a number of different strategies. Ours is a completely supervised approach, right? So the gold standard is the expert radiologist's determination of what's right and what's wrong, because there's no other gold standard available for the particular application I talked about at the end, the head CTs. And so eliminating false positives, I mean, the trivial way to eliminate false positives is to drive up your false negatives, right? Anyone can do that. Obviously, you need a lot more data, and certainly a lot more normal data is always helpful, right? Because then you get exposed to the normal variation that's out there, and that'll help with your false positives. But then, you could use strategies like synthetic data, for particular false positive issues that you're having, changing your class balance of positive and negative cases. Approaches like that are the kind of low-level data level approaches. And then no doubt there's some architectural changes you could make to your model designs as well that would help. So there's no single answer to that, but there's a number of different strategies that can help.
I just want to say thanks for both of you guys for the talks. It was really great hearing kind of the whole healthcare system and getting a good picture. My question is more for Dr. Mukherjee. I wanted to know more about you were talking about how you have the black box setup versus kind of figuring out why these results are coming up, like figuring out the specific reasons. Maybe if you could discuss a little bit more about if you've used any of that sort of technology, or if you see, what are some of the challenges that you might see as we sort of build those sort of technologies?
Sure. Certainly for our scientific work, we are trying to use approaches that are more explanatory. And so that typically means that we want to know why certain features are being selected if they're being selective. So we use only approaches that give us that information. A lot of the approaches we use, since we're trying to make discoveries, are actually unsupervised approaches. So that makes it incumbent on us to collect enough data to make those unsupervised approaches work, which is not always easy. For the clinical application I talked about at the end, it's kind of the opposite. So it's a very strictly supervised approach that'll work on smaller amounts of data because it's hard to collect huge amounts of data like that. The black box is what we're dealing with right now there. But since we're looking very closely at the answers it's giving, and the answers are relatively simple answers, yes or no, we think that's acceptable for now. If it starts to break down for some reason, and that would be, then we might need to change our approach, but so far there's no evidence that it's not working.
Hi, my question is to Dr. Mukherjee. Thank you for the insights. You mentioned that the solution you're presenting aims at helping hospitals in the remote locations who cannot afford an expert doctor to diagnose. But my question is, will this solution still require machines like MRI scanners, or because hospitals at remote location cannot afford these machines as well? So
That's a very good question. The good news is, so the application at the end is on CT scanners, right? And the CT scanners are much cheaper than MRI scanners, and they're becoming cheaper and smaller. So a lot of them now, the number of CT scanners in the emerging countries is increasing a lot. And actually, more of the shortage is for trained radiologists to read them. I think, for example, in Tanzania, there's one radiologist per 1.5 million people, but there's more CT scanners than that. In fact, when I was speaking a few years ago to the CEO of one of the big CT vendors, he said, whenever I make sales in these countries, they ask me if I can sell them a radiologist as well to read the scans. So obviously this addresses that problem. And it's no longer just the emergency department. CT scanners are now small enough to put into ambulances. So you may get your CT scan if they think you're having a stroke in the ambulance before you ever arrive at the emergency department. So you would want wireless connectivity there and, have faster diagnosis hopefully made, before, because as I said, you have 60 minutes before your intravenous TPA injection. So every minute counts there.
You just showed one image in your slide where it's detecting the hemorrhage, original CT, and then detected one, red color region. So what kind of deep learning algorithms do you use in those scenarios to color the region? Or
Yeah, I mean, it's nothing too unusual in the deep learning space. These are standard feed-forward convolutional neural networks. They use some of the most recent adaptations like dilated receptive fields and residual networks and so forth. But they're fairly...
But so the input would be the image of CT scans, but what's the output? Well, what's the label when you're training it? Like it's the ROI, like a rectangle, square, or what?
Yeah, we can use different kinds of labels. So we can use labels for the entire image. Is there a hemorrhage or not? We can use labels, that for every slice, is there a hemorrhage on this slice? We could use labels that are more fine-grained if we're trying to measure volumes. So actually trace out the, hemorrhage. So it depends on what the application is. And certainly some of those are easier than others, and much more laborious.
And Stanford has I think opened some AIMI lab that is open sourcing healthcare data set, that they're creating a hub of the data set. So is UCSF also in that initiative or towards that?
I don't know the answer to that. I think that there's more of a move to open source, or more data, or open access more data. Certainly on the research side, we do that as a matter of routine now. So there's more and more publicly available data sets available for research. In the clinical environment, you have to deal with the privacy issues and security issues. For imaging, it's a special problem. You may have seen the news reports recently that the scanners are now often the most vulnerable part of the healthcare system in terms of networking. They're almost like DMZs, right? But not sufficiently demilitarized, I guess. So hacking that information is a problem, and then just protecting the privacy. Sometimes with these medical images, they can be identifiable, with certain types of pathology. I mean, not all pathology is very common. There may be rare pathology, and the person may be identifiable because of the rare pathology. So you have to keep those in mind if you want to share data. But I'm sure you have a lot of insights into that as well for your health system.
No question. I mean, security, and you have to understand, in our security office, there's a picture of me on the wall with a bullseye, because I'm the one that's constantly pushing our security people to decrease the security, because it's so difficult. It's so difficult to log in to these devices. I actually measured it. It took us 42 seconds to log in to a point from the time we scan our badge to the point we have a patient on the screen. So 42 seconds times 50, 60, 70 logins a day. You're talking about a lot of time, right? So security is no question an issue, and you guys might remember a few years back, Home Depot was hacked, and the portal of entry was a thermostat. And this is before Nest, right? So yeah, I mean, the way hackers can invade an organization is becoming more and more creative.
My question is for both of you guys. First, I'll start with you. Dr. Mukherjee, now, seems like you are working on the vertical arena of TBI, but what about having computer vision into identifying stages of wound towards cancerous cells, things like that? Is that something, that arena you guys also studying, or just typical one? Yeah.
Yeah, I mean, we have a vertical in the neuro space, certainly. I mean, but there are dozens or hundreds of applications, for AI in medical imaging. Some of them are being explored now, but certainly not all. And, I think the only limit is your imagination for what you can accomplish there.
Yeah,
Is your hospital working on those, or no? That was the question. That do you have different departments or different leaders like you who is focusing on that?
Sure.
Those?
Yeah. I mean, there's work going on in these other areas at our institution and other institutions as well. And there's news coming out all the time about different potential applications. But right now, the number of possible applications exceeds the number of certainly research efforts, and far exceeds the number of solutions right now.
Yeah, I can add to that. I mean, the academic centers are doing a terrific job, in the areas that they're working in. But I'll tell you, vendors are doing an even better job in many ways. So that application exists. So I spend most of my time looking at these things. And, I have providers and nurses and all kinds of clinicians asking me, I need to do this, I need to do that. So that application exists. However, the AI part of it is not very good. But the tool that actually, now he's a friend of mine, he's developed is phenomenal, where you can use your smartphone, take a picture of this wound, and wound staging is not that hard. So that's actually probably not going to be, because it's too easy to do. A nurse can do it, anybody can kind of do it. So it's probably not going to be an area where AI is applied probably because of cost, even though it might be an easy problem. But if you look out there, there's lots and lots of these applications. If you've been to a conference called HIMSS, so HIMSS is a really great venue to learn about HIT. So if any of you are really interested, look at any HIMSS conference. But there's one annually that's typically in Orlando or Vegas that has usually 30, 40,000 people there. It's quite an event, and all the vendors are there, and you see these types of applications.
Okay. If I may just throw a plug in there for some of our work. I would also suggest you look at some of the case studies in my book. Pratik has a case study there, and we also have 15 other case studies. We are focusing quite a bit on the California initiative to advance precision medicine that Pratik spoke about. And there's a lot of efforts happening there across board. But I think the future is not so much are we doing things or not. The question is, are we doing the right things? Because I do not think we are anywhere near, unless you both disagree, towards this idea of an artificial general intelligence for medicine, where you can take Pratik's work and apply it to pain, and apply that to kidney disease, and apply that to whether I'm going to be happy with my pill or not. That ain't happening. So this is going to be successful in targeted use cases. The question is not, can we do it? The question is, what are we going to go after? How do we demonstrate ROI so that you get money to do the next round? And how do you demonstrate outcomes not just to patients, but also to payers, whether they are commercial or government payers? So the universe is large, but in order to be successful, I think we have to be more targeted towards use cases that will allow us to succeed. Is that a fair statement?
Absolutely.
Yeah, and the turnaround time for an application, that's a really, really good point. We absolutely look at the ROI. And so our average turnaround time is 18 months. So if you have an application, no matter how great it is, no matter how wonderful it is, we're going to spend at least 18 months in most cases before we even reach for our wallet. So it's very, very hard, especially if you're a startup, which a lot of people are these days.
So second question to you, Dr. Ghauri. You mentioned the problem of having patients with sepsis and being discharged. I personally have encountered in a community health setting in which patient was not diagnosed at the time of discharge, and you mentioned some of those key players in Northern California, and it was patient belonging to them. End of the day, they all come down to somebody like us to see you guys didn't do it right. So the problem that you identified, what is the solution for that? Because at the time of discharge, it's not done, and you just got it out. So
yeah, I didn't get to talk about it, but the last point here, this burnout problem, it's a very serious problem. And I myself, I wasn't burning out, but I was pretty close. My wife was there. She was burning out. My wife is an internist as well. This was about 5, 6 years ago. And the problem is that now with all this new, all these new ways to look at patients and examine data and get a real correct, a proper answer, we're not doing things properly. We're not, and in many cases, we're not really helping our patients. So on the one hand, we're not really helping our patients. They're not getting better. They're coming back. So we do everything right for the patient. They're coming back next month, even though we did everything right. Number two, we have all this regulatory pressure, right, on doing things, documenting them according to whatever the guideline is. And then number three, we're not getting paid. And by the way, we get paid very well. I think, both of us on the stage can say that physicians get paid well. But a lot of us don't agree. A lot of us say that what we got paid last year is what we need to get paid this year, otherwise we're not going to be happy. And so this burnout issue is critically important, because if I'm not engaged with the care of my patient, I'm not going to do a good job. The literature is exploding with the data, right? I mean, if you're not engaged, if you're burning out or burned out, you deliver poor care to the patient. And you're miserable yourself, and your risk of suicide. Physicians are the #1 risk for suicide in the United States in 2018. It's a tremendous problem. So the reasons for why we discharge patients that are septic, the reasons for why we discharge patients that come back the next day with a different problem, they're very, very complicated. But I think the burnout is a very common reason for why people are, especially on the physician side, and nurses as well, all the clinicians are in the same boat. But I think from the physician's perspective, that's a very underemphasized reason for a lot of the poor quality that we're seeing.
So I think we'll do maybe, 3 hands up. I think those will be the last 3 questions for the evening. And then...
Yeah, unfortunately, Mike is with me, so...
4 hands then. Very easy, 4 hands.
First of all, acknowledge of my ignorance. I come from the finance and banking industry. So a couple of questions I have in my mind when I did spend some time in understanding the data interoperability challenge that you mentioned. So, spec like fire, FHIR, is that playing any role in this interoperability challenge? That's one question, and I've got another question. So, or anything you want to share?
Go ahead.
That. So the second question I have is actually for both of you. When I think about the PII information, particularly I'm, talking about the finance industry, and when I see the healthcare industry, particularly the image type data, I don't know whether there is any specification that, because it's very difficult to take the image and say, oh, this is the image of that person, right? That's the definition of PII, right? Yeah. So is there a different specification that guides or helps to do more research on the image side versus, my home address is blah, 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 that's a different PII challenge. So these are the 2 questions I have.
Please do.
Okay. Right, so there's definitely special considerations for image information. So the image metadata is anonymized the same way you would anonymize any other information. So any name, social security number, date of birth, or anything like that associated with the image, the patient associated with the image would need to be taken out in order for it to be properly de-identified. But even after you've done that, there are possible ways to re-identify the image. Like one is, with all of these head CT scans, or brain MRI scans, if they're high resolution enough and they cover the whole face, then you could reconstruct the face, from the images. And by looking at the face, you might be able to identify the person. And there's some work going on in that area where there's a paper actually from the two investigators at the FBI who are trying to do identification based on head CT, facial recognition. So you might want to deface the images, quote unquote, meaning remove the skull and non-brain tissues, including the face, in order to properly de-identify it. That's still a gray area right now because most of these images are not high-res enough, and it's actually pretty difficult, even if it was high-res, to do that kind of face matching. But it is theoretically possible. And then there are deeper, longer-term concerns, like the connectomic data I showed you, where we're tracking the brain network pathways. So it's been shown in research studies, from large groups of volunteers that if you have a connectome of a person whose identity you can potentially match it to a group, where it's unknown and see if that person is in that group, and match that person's connectome to the group, any individual person in the group and find if there's a match there. So that would be a way of re-identifying the patient. And so there's good evidence now that it's possible. It's not clear how accurate it is right now, but there's no question the accuracy will improve as our technology improves and our connectomes get more and more granular. And if you think about it, as I was telling Prashant earlier today, that could be the ultimate biometric, because you can take away your fingerprints, cut off your hand. You can even take out your eyeballs so they can't do retinal scanning, but you can't alter your connectome except by incredible training over many years, so that it doesn't match. And you still can probably find invariants that are individually specific, to match the connectomes. And so there's no way to change the connectome without changing yourself, basically. So, that's a longer-term concern for this kind of data if, many connectomes become disseminated, like publicly.
Yeah, but if you write your data to the blockchain, then you don't have to worry about it. So the fast healthcare interoperability resources, the FHIR standard, is absolutely already making an impact. The issue is that developers are a little bit slow to adopt. And for the audience that don't know what FHIR is, it's a new standard. It's like the HTTP hypertext transfer protocol that we all know in a browser. It's a protocol, and that's what FHIR is too. It's just a protocol. It's a way for the 17-year-old in a garage to actually reach into Cerner or Epic or whatever database you have in your organization and pull data and use it in their application. And to give you an example, there was a researcher here in California, maybe even at UCSF, and this is a story that I heard about 2 years ago when FHIR was first released. She was planning this big cardiovascular study. I don't remember what the disease was, but she had this huge plan to get like 25,000 patients, and it was a cross-international study, like 7, 8 different centers. And her son was 17 years old, and he heard her talking about this. He said, hold on, Mom. And then basically the next day, he wrote her an app that they published to the Play Store. And by the end of the week, they had 10,000 data points. So 10,000 people downloaded this app and gave the data to this researcher. So this study that would have taken 3 years, 2-3 years, was basically probably would have been done in 2-3 weeks if they continued down the path. The problem is they didn't do any of the IRB and the things that you need to do, before.
He's probably working for Cambridge Analytica now.
There you go. So yeah, no question, FHIR is already changing, the way we do business.
I'll just add one thing to that, Babar, right? I'd say the thing is not FHIR or not. It's a protocol. The question is, are we going to change the mindset in our industry, and more importantly, as voters, to demand that our health records belong to us, and also demand that we get paid for our health records. And every time somebody uses it for research or therapeutics or sharing, the patient should get a piece of it. Heck, it's the patient's data. Today, the law is written in a way that the patient actually has no control over data. The patient doesn't own their data. And you go file a case against either of these two gentlemen, not that I recommend it, but you will lose, because the government doesn't recognize you as the owner of your data. And I think that fundamentally has to be changed. For true interoperability to happen, the protocol is one way of getting there, but it still means that the patient, and that's where I think some of the blockchain stuff again comes in. Because if we are able to enable this environment where people are able to monetize their assets and they're able to do it either for money or for the greater good, it doesn't matter. We're all capitalists here in the Silicon Valley, aren't we? And that's what we want more of. 3 more questions and then we have to end. The only 3 gentlemen who put their hands up and ladies.
Yeah, question to Dr. Ghauri. So this is a general question. So some in like physicians, is there any rule? Any hospitals have that physician need to check these many patients minimum they have to check. Is there any rule? Because some patients are very hurry. Hey, I'm done. Okay, I need to pick. So is there any rule? Is there? It's a general question.
So your question is there a minimum standard for a patient? And the answer is yes. I mean,
What is the count?
what is the?
Is there any count like 10 patient minimum the patient need to check? Is there any count?
Oh, no, there's no count, but there is a minimum standard for what we do for a patient. So, evaluating a patient requires taking a history, doing a physical examination, and creating an assessment and plan. I mean, some people can do that. If you come in with an arrow sticking out of your head, right, that's pretty easy. Within 1 minute, you can make a diagnosis. You can do that whole thing. But if you're coming in with vague, nausea and crazy symptoms, that can take hours or days or weeks or months. And sometimes many times we don't find the answer.
Sometimes patient very hurry.
And that's me. The healthcare workers are the worst patients, and so I'm the one that's always rushing. Whenever I go in for any type of service, I'm always rushing them.
An arrow sticking out of your head is penetrating TBI, and it's not easy.
So I have a question about sort of evidence versus eminence-based machine learning, I guess. So what you've described is I see a lot of in deep learning research papers. There's dozens and dozens of machine learning papers on deep learning and MRI images and so on. But a lot of the labeling for those images is coming from human labeling, and you could argue although it feels like we're doing using data, and this feels like it's evidence-based, it's really eminence-based because the labels are coming from standard medical practice. And so my question is really, to what extent are you validating the outcomes and trying to look at really what is the longer-term outcomes rather than just trying to simulate what the sort of the eminence of the doctors who are providing the labels?
That's a great question. I think it depends on what application. Some applications lend themselves more to evidence-based training. So those applications are ones where it's possible to get actual. So for imaging, the gold standard is typically microscopic analysis of the tissue. So if the patient is going to surgery and they're going to have the tissue removed, or if it's a disease process where the patient will die soon, like Alzheimer's, and they're going to go to autopsy, or if it's a process where you can wait a while and then get outcome data. For in the neurospace, it might be cognitive data, behavioral assessments, and other things. Functional disability assessments. In other parts of healthcare, it would be other outcome measurements. So those are all objective markers, but you need to wait for those markers and have them, large amounts of them available in order to train your data. In the neurospace especially, that's not happening, right? Because very few patients go to autopsy, and surgery is there only for a small cohort, and they typically, are in any particular disease process, it'll take you a while to collect, that much data there. Outcomes can take years, to be meaningful for particular disorders. So that's the reason why, in many of these applications, and for this application that I spoke of at the end here, I don't really see an alternative, actually. So they have to be eminence-based. And by that measure, you're not going to exceed human performance by a lot. You may exceed, the average expert. You're not going to exceed the best experts, especially not a consensus of the best experts, because that's what's giving you your training. But in these other applications where there is more objective data to be had to train against, then it's possible.
Thank you very much for your talk. And my question is, like, in one of the case you showed the hemorrhage was misdiagnosed basically by the radiologist. And I believe, like, when usually you go to the hospital, there are multiple diagnostics, like not just imaging, but you might have blood test or other things. So are there certain systems which could alert the doctor, say, probably, you know, because of the blood reports, maybe that is something they have to dig into deeper? And like, are we just relying on the imaging, or we look at the other modality of diagnostics to determine?
So in the acute emergency setting, to detect blood in the brain, it's the CT scan and nothing else. I mean, you can do some of this with MRI as well. Like for certain stroke patients, you know, if they want to bypass the CT scan, they can do an MRI and get mostly the same information. That's, you know, in 0.0001% of the patients, you know, at specialized centers. But for this particular application of detecting acute blood in the brain, it's only a CT scan.
I'm laughing because the radiologist says that this is the only way to do it. But I'm laughing because he's right. I mean, the gold standard in the U.S., no question about it, is this CAT scan. You know, but in many other countries, you know, and I see a very diverse audience here, there is no CAT scanner, right? I mean, there are physical diagnoses. There are other things that can be done, specifically for hemorrhage. But the problem is, you know, you might diagnose it, but if you don't have a CAT scanner, you probably don't have an OR, you know. So you're kind of screwed either way. But, you know, the answer to your question is there are other ways of making a diagnosis.
And yeah, there was a tweet competition that's up on the web now of how to demean an entire medical specialty in one tweet. I invite you to look at it. But one of the tweets was emergency room. You know, so you go up at the, you know, to a conference like I'm here. You pick up the mic and you say, emergency room doctors. They are family practitioners with a CT scanner. And then you duck as objects get thrown at you.
And just one more question, because like I understand we are talking about the precision medicine, but as both of you mentioned, the scenarios where the patients are coming back basically, right, after the operation or whatever. So how about looking at the predictive medicine, how feasible it looks at this point?
Yeah, good.
Predictive medicine. I mean, so we've been doing predictive medicine for 100 years, you know. Right. So, you know, if someone asked me what machine learning is, I would say it's multivariate statistics, right?
Right.
I mean, how else would you define it, really? And I've been, you know, studying machine learning since I was an undergrad in computer science 30 years ago. But, you know, so, I mean, we've been using multivariate statistics for prediction in medicine, you know, I don't know, centuries probably, right? You know, basically, as soon as statistics are invented, they get applied for this purpose. And machine learning is the newest iteration of that. You know, and things like randomized controlled trials came out of medicine. Now we see them in the technology space as A/B comparisons and so forth, you know. And it feeds back, so now in medicine we're doing more adaptive designs rather than single, very expensive, large, you know, randomized controlled trials for single drug, you know. So, you know, these concepts go back and forth between medicine and the rest of technology space. But, you know, yeah, I would say machine learning would be great for predictive medicine because it's, you know, what we're going to base most of our predictions on in the future.
Because like I see like most of the cases like after the post-operation, there are a lot of complication, and that's the probably contributing a lot to the mortality rates. And usually that's the scenario where the doctors have no prediction model in place.
I can share a really quick story about this. So literally a month ago, we were sitting, we have a readmission, it's not a readmission committee, but it's a readmission meeting that we have. And again, very smart people in the room, probably 7 or 8, you know, very varied, you know, interdisciplinary group get together, clinicians and care coordinators and all kinds of people from the hospital. And we had only one task. We've been doing this for about 8 months now. Every month we pull data. So these people spend at least 20 to 30 hours a month creating this list of patients with key metrics, you know, related to that diagnosis. And one of the metrics that is universal to all the patients that we've looked at is this thing called the readmission score, right? So we've been doing this for 8 months, right? So 2 months ago, I looked at this readmission score, and I'm seeing they're all high, you know, and all these patients got readmitted, so it made sense. So we said, you know, let's do this. Let's for next month, let's pull patients who didn't get readmitted, who had a very high readmission score, right? So then the team went out and they pulled the data, and it was great, you know, again, 20 hours spent doing that. We're looking at all this data, and then somebody asked, I think it was me actually, that asked, you know, what is this readmission score? You know, we're using this thing. And we started talking about it, and the care coordinator started saying it's this, it's this, it's this. There are no social determinants of health in this score. And we know that the social determinants of health are probably 70 or 80% of the weight, you know, of being readmitted, right? If you don't have food at home, or if the roof is leaking, or if you have carpets and you're an asthmatic, I mean, these things are critically important to your care overall, and specifically in readmission. So here we are now using this readmission score for 8 months, and not just in that meeting, but every single day, every single patient that gets discharged, people are looking at this readmission score, and this readmission score is completely useless. And it just illustrates, you know, what we're doing on the front lines. We're using this data kind of blindly without really any real knowledge. And we're told, you know, use this thing, and, you know, many of us will buck and say, I'm not using it at all, forget it. And then others will say, you know what, we'll just do it because you're asking. And it's just a big waste of time in a lot of cases. And again, this is where you all come in, you know, to perfect some of the things that we've been talking about this conference, and what I've seen today is really, really exciting, because this is how we're going to, you know, form our readmission score of the future.
So on that note, I actually was busy because I decided that it would be unfair if you went back without some added weight in your hands. So on that note, I just want to thank you all first. End of a long day, 7:30 in the evening. Most of you stayed back for the whole event. Thank you very much. I'm sure it's because of our wonderful guests here. Please give them a loud hand. I would like to, none of this would be possible, of course, without the people who have tirelessly worked to get this event done and to really make it happen. Shabal, thank you very much. Ian Gomez does all the work but prefers to hide at the very end of the room. But he's actually extremely tired. Saurabh has been the magician in making sure not only this happens, but also our speakers got here in one piece on time and were well fed. And for all of the publicity around the event. Thank you, Saurabh. So on behalf of H2O AI, we really think that we are pushing the boundaries on science. And like I said, we wouldn't let you go without some books for your pain. The elements of statistical learning by members of our H2O team. Dr. Mukherjee and Dr. Ghauri, I look forward to seeing you very much soon.
It's wonderful.
We hope this to be a community. We are going to be doing more events like this, but it's not just going to be events. As I said, we are also going to be working on some concrete efforts with various leaders in the space and our partners to actually, all we read about in the newspapers is Governor Schwarzenegger coming in as Terminator to do a colonoscopy that no one wants. There's more to AI than that. AI can actually do more good. We sincerely believe that, those of us who are in the health and medicine fields. And we thank you for your support and look forward to seeing you again soon. Thank you.